Hi guys, welcome back to the show. Today we have another really cool episode on PCOS, and it is with an old school guest, Dr. Bassel Wattar. He is a London-based consultant obstetrician and gynaecologist, associate professor and accredited specialist in reproductive medicine, menopause care and minimally invasive fertility surgery. He leads advanced clinical services and research programs with over 80 peer-reviewed publications. I hope you enjoyed the show. I hope you learn loads, and I will see you soon. Amazing. Dr. Bassel Wattar, thank you so much for coming again. You are the original OG, one of our first guests.
Thank you.
And you're back again to speak about something that, again, I have no knowledge in, and I could only entrust you to come and speak about it, PCOS. Firstly, I'm going to ask you to give us a short introduction for those who don't know you or who are new to the podcast. Will you go ahead and introduce yourself for me?
Sure. So thank you very much for having me back. Always a pleasure. And you're doing great work with this podcast, disseminating, knowledge and information on women's health. So I'm Basil. I'm a associate professor of reproductive medicine. My main field of sort of specialty is around women gynecological health and fertility and endocrine disorders. I lead a research group at Anglo-Ruskin universities where we do different types of studies, but mostly focus on women's metabolic and endocrine health. And I'm a consultant in the NHS at Epsom St Helier Hospital, where I'm one of the IVF consultants, but I lead a specialist endocrine gynecology service, looking after women with PCOS, with complex menopause issues, with PMS, menstrual health issues, and all these, slightly underserved health conditions that thousands of women suffer from. So, and always a pleasure to be speaking about about women's health topic.
Amazing. Very complex indeed. So, I'm going to go straight in. As you know what I'm like. Forget all the small talk. Let's go straight into it, because time is of the essence, and I'm going to try and extract as much as I can from you. First question is, what exactly is PCOS and how is it diagnosed?
Certainly. So PCOS is quite an interesting syndrome. And by syndrome, we mean that it has not just one symptom, or it doesn't affect just one physiological system in the body. Rather, it affects different systems and it has multiple symptoms. So that's what it often makes it complex to diagnose. And in essence, the core origin of it is that there is disturbance and imbalance in the core hormones that are in a woman's body that governs her reproductive and metabolic and endocrine health. And as every woman knows, every time of the month there is the synchronicity between several hormones that lead to a period to happen. So what commonly happens in a woman with PCOS is that her body loses that synchronicity for various reasons, and we don't all understand them, between the brain, the ovary, and other organs like the pancreas, like the uterus, and so on. And that leads to the absence or irregularity of periods, as well as other symptoms that often manifest, such as excessive hair, what we call hirsutism in medical terms, acne, weight gain, and other health problems as well that we can discuss. And that's what often made the diagnosis of PCOS very complex, because commonly a woman would present with one symptom, but then unless you really dig deeper behind all the other entities in this syndrome, you can't really make a formal diagnosis of it as a syndrome. So currently luckily we have a robust diagnostic criteria. It's called the Rotterdam criteria, after the city in Netherlands, basically, when it was conceived. And in the Rotterdam criteria, a lady with PCOS will be diagnosed as formally having PCOS in adulthood. It doesn't apply for teenagers. Teenagers is slightly complex issue still, but basically you need to have 2 out of 3 elements. Number 1, you need to have irregular or absent periods. Number 2, you need to have excessive hair on the skin or high testosterone level in the blood. Number 3, you need to have appearance of multiple cysts on your ovaries on the scan. So if you tick any 2 of these, then you get the formal diagnosis of PCOS. And while for me today, I'm making it sound easy. The reality is we have to appreciate that a lot of women struggle to get that diagnosis because of lack of awareness and knowledge, even among health professionals, about how to really diagnose it, as well as barriers to accessing full diagnostics. So it's very, very common, unfortunately, that it takes more than 2-3 years for a lady from the time she's, experiencing the symptoms to actually get diagnosed.
Yeah, that seems to be a common theme of the delay in diagnosis from lack of awareness, not just from the individual suffering from it, but actually from the healthcare professionals, from the GPs.
Correct.
It seems as though it's only certain specialized people within the healthcare profession who understand these conditions really, really well. And I'm like, why?
Yeah.
Why is that? It should really be something that all GPs are trained. I understand, obviously, within reason, women's health is really, really broad. But I think when it comes to the menstrual cycle and conditions such as PCOS and endometriosis, and really there should be thorough training for all GPs.
Yeah.
So I digress a little bit. But the other question I was going to ask you is, why does PCOS cause things like irregular periods, aints, or hair growth?
Yeah, sure. I mean, I fully agree with you, and I think we have to acknowledge that most GPs in the UK are hardworking and they want to help patients. But the reality is that they don't get exposed to PCOS as a learning material or item in their curriculum, and this is why we recently launched a national course that's dedicated to GPs with a charity, because we want to share that knowledge that they just don't know a lot of information about it, which presents that barrier to helping patients. So I think there's more work to be done on education level. I fully agree. So as we discussed in PCOS, the common sort of pathways that there are several hormones, FSH and LH, that are secreted from the brain to the ovary to recruit an egg every month, once a month. So there is only one egg that is produced, and that in preparation for a lady to get pregnant. That's the basic physiology. And what happens in PCOS, what we think is the sort of, I'm oversimplifying it. If we have any health professionals listening, I'm oversimplifying it for, obviously we have a lay audience.
Yeah.
The core is that there is disruption in these signals between the brain and the ovary. And what happens is that in the ovary, there are several follicles that get ready to become a mature egg, but then they get arrested in their development. So they become like smaller cysts, and this is why it's called polycystic ovarian syndrome. So you don't have this ovulation that happens every month, and then you get one follicle after one follicle after one follicle coming and arresting in their development. And that gives that textbook appearance on ultrasound of an ovary that is filled up with multiple cysts. They're not actually cysts, they're follicles. They're on their way to becoming a mature egg, but they just get arrested. And that hormonal imbalance, then it provokes a chain events of furthermore hormone imbalance. So in itself, it causes insulin resistance, whereby the body does not respond to its insulin. That provokes obesity and very fast weight gain. So we know that women with PCOS do not process sugar as efficiently as someone who does not have PCOS. So very commonly they'll come and say, look, I eat very healthy, yet I'm gaining weight, and it's so hard for me to lose the weight. And they get the sort of paternalistic advices like, go lose weight. It's hard for them. We have to help them with the specific measures. And then the other element of this is that the ovary secretes androgens, which are the male hormones, testosterone. And in this condition, because of that situation where there is that arrested development, there's the lack of synchronicity with the hormones, then the woman's free testosterone rises, and that gives this excessive hair. So you can see it's almost like a vicious cycle where a woman gets trapped in it, and that one symptom is leading to the other, to the other, to the other. And then the rise in insulin resistance is feeding obesity, and obesity is feeding more rise of insulin resistance and more dysregulation of her basic hormones. So it becomes like a trapped syndrome where there is always, only like gradual chronic progression towards worse health outcome, basically.
Wow. I was going to ask if PCOS is linked to weight gain, but you've just answered that question and why, and you've also answered why. What can women who are gaining weight from PCOS because of like insulin resistance, what can I do to help them lose the weight?
I think, look, the first step is understanding their condition. Now, a lot of women with PCOS present, they don't know that they're actually PCOS, and they have not had any advice or, recommendation from a qualified health professional how to manage their health. So that's the first, the first step is knowledge, like get more knowledge about your condition. The second step is understanding that there is a core element of insulin resistance in this, which by de facto means that sugar is the enemy. So I know everything nice in life is sugary and sweet.
Sugary
so
and sweet.
we all like our cookies and donuts and so on, and I suffer from this. But for women with PCOS, it's particularly harmful because their body does not process sugar efficiently, and it's so easy for them to switch the sugar, excessive sugar, into fat very quickly. And then becomes very hard to shed that fat, even with like strenuous exercise and life intervention. So avoidance or limiting carb intake is key. Now, again, I am oversimplifying it sitting in my seat today, but I think we need to give like specific advice. So following particular dietary interventions that can help with that. So besides just the education to avoid sugary items, a cookie or something, or a McDonald's, for example, ice cream or something like that, but also they need to follow a specific lifestyle dietary intervention, such as a keto diet, a intermittent fasting diet, a Mediterranean diet. All these diets have been shown to have some benefit, but we still don't have robust research about it.
Wow. I can say that with PMDD for myself, one of the things that, again, there was no answers everywhere I looked, but because I'm so self-aware and I'm like, I'm not going to give up on this. I'm going to do a lot of research. And one of the main things I found was that changing my diet really did make a huge change. I mean, a huge change. The Mediterranean diet, I'm very lucky, very fortunate that I'm Angolan, so we follow a Mediterranean diet anyways. I cut out alcohol, I introduced a lot of fruits, a lot of veg, so it really does help. And I wonder why it's not being pushed more. I mean, you go to your doctors and they say, yeah, lifestyle changes, but I think they need to be, like you said, more specific in terms of, look, you should really look at maybe following this kind of diet, Mediterranean diet, like you said, a keto diet, cut out the alcohol, and so yeah, it is about education. Can you tell me, if you have PCOS, does it make it more difficult to fall pregnant? Can you explain that?
Sure. So as we discussed, the core sort of pathophysiology, I'm using big words here, is that there is lack of.
You like big words.
It's like
Google it.
The main thing that is wrong, basically, in the physiology is that there is lack of ovulation. So, in if a man and a woman are trying to get pregnant, what happens is they time it at the time of the month to have timed intercourse when there is ovulation, and then they fall pregnant.
Yeah.
And by the way, I don't know if everyone knows that, but a very healthy couple, they have about 30% chance per cycle to fall pregnant. So as a species, we're not very efficient in procreation as humans. So, many couples will have to try several months. It doesn't happen like in the movies where you just get drunk and they get pregnant immediately. So for a lady with PCOS, what's happening is that she's not ovulating. So no matter how many months she tries, if she's not ovulating, she's not going to fall pregnant. However, the misinformation happens is that it doesn't mean that she's infertile forever. So luckily, we have very, very simple treatments. They're called ovulation induction agents, where basically it's a simple tablet like letrozole or clomiphene that we give to the lady at the first 5-6 days of her cycle. And what these tablets do is that they sort of override the ovary to produce an egg. And then once that happens, she's almost back to a normal situation where she's producing an egg, she's ovulating, she can have timed intercourse, and she can fall pregnant. So there are treatments, and I often hear also the flip argument is that I see a lot of patients in my clinic, they come and say, we're PCOS, we were told our only hope is to have IVF, which is factually incorrect, as in, like, not every woman with PCOS needs expensive and invasive IVF. IVF has its role in someone, for example, who tried several rounds of ovulation induction, they could not succeed, or say in a couple where the woman has PCOS and the man has reduction in his sperm, then IVF might be warranted, for example. There are like cases where IVF is warranted as a first line intervention, but in a like an Hippocratic oath approach is that ethically you need to give the least invasive and the cheapest intervention to your patient first, and that's why ovulation induction is the go-to. And so it's very, very simple, and once they do that, there's a high success rate in falling pregnant within 3 to 6 months of doing this process. Basically, it does take patience, as I mentioned, is that even when they are ovulating, it takes some time to fall pregnant, so it requires quite a bit of concurrent care and support from the healthcare professional that maintain the course. It might take a few months, you need to have a lot of scans, but you can fall pregnant very normally, basically.
Doc, can I ask, just out of my own ignorance, because I genuinely want to know and I don't know, could your PCOS turn into an endometriosis if you're not ovulating? Is that a possibility?
Not quite. So there is we're picking up that some women with PCOS can have endometriosis. There is no common pathway for the two conditions to cause each other indirectly. So there are many reasons why endometriosis might happen. The most common thing is something called retrograde menstruation, where basically the menstruation doesn't go outside of the body, it goes back through the tubes inside the abdomen, and seems that it's one of the most common theories why endometriosis happen. So in a woman with PCOS, it happens the opposite. They're not actually menstruating altogether. So there is no direct link to them. There is some very early research to suggest that actually exposure to PCOS or endometriosis can start in the womb, and it can be modulated by the mom's own hormone, whether it's higher estrogen or higher testosterone while the lady is pregnant. If the baby is a female, they can be at higher risk of developing this condition or that condition, PCOS or endometriosis. But this is very, very weak and early research, so take it with a pinch of salt for now. But some helpful directions in terms of us exploring it a little bit further, because I see a lot of women with PCOS who come to me and say, as a fertility specialist, like, I'm worried if I have a girl, is she going to have PCOS as well? And we know that PCOS is not directly hereditary, so it's not like it's a gene that is passed, but it can run in families, and it seems that there is an element of what we call in utero exposure. So if the baby fetus or baby embryo is exposed to the mom's high androgens, high testosterone, there is a slightly higher chance of developing PCOS later on. But again, very early research, we don't have robust information about that
on it. Okay, and let's talk about mental health.
Yeah.
How does PCOS affect mental health, and like what support is there available? Because imagine being a young woman who wants to have a family, build a family, and you have PCOS and you're not able to, and you don't know what your options are and what choices you have.
Yeah, I know. This is one of the biggest challenges we have in the NHS right now, because there is simply not enough resources to deal with all the mental health difficulties that patients are facing, particularly women. We know that PCOS is associated with higher chance of depression, anxiety. There is a lot of eating disorders, so the other bulimia or the other way around. There is also quite significant body image problems, because obviously of the obesity and increased weight and the hirsutism, so that can generate quite substantial body image issues. But unfortunately we don't have currently, I think, in our healthcare system enough support for this, because even for me as a secondary or tertiary specialist in this area, even if I'm diagnosing it or detecting it, there's literally no pathway where I can say, go see a psychiatrist or go see a counselor in the NHS that I can refer these patients on. So at present, unfortunately, we're largely limited to say seek help via your GP, and, which I strongly emphasize, get peer support and reach out to charities. For example, I give a big shout out to the Fertility PCOS charity that I support and work with closely. They do amazing work in terms of offering peer support, trying to talk about PCOS and how to bypass the issues. And I do believe peer support can offer a lot of, benefit to patients. So that's where we are right now. And I think we definitely need a bit more sort of institutional support to manage the mental health element that is associated with PCOS.
What do you think the patients can do in terms of like assisting in, because I do think it's a combined effort between the healthcare professionals and the patients. What do you think the patients can do to assist in the push for better options when it comes to mental health within, for instance, if you're diagnosed with PCOS, like what can we as the patients do to push better assistance? Or is there nothing that we can do? Is it just one of those things where you have to wait until a solution has been found?
No, there's definitely something. Always some patients can do something about managing their own health. So I think at the most basic level, we're very fortunate to have a lot of content online nowadays that is with health experts, where patients can look up for reliable information. I don't recommend the Dr. Google approach, but you'll do
it. We come out with about 10 different conditions.
But luckily there is a lot of resources nowadays where patients can start to educate themselves about the process, because as I described it, PCOS is a chronic disorder where there is this state of helplessness where you feel like you're unable to gain or control of your own health, and things are just like snowballing towards a worse state. So with a lot of success, when we see is when you spend time to educate the patient and explain, this is 1, 2, 3, 4, what is you're experiencing, this is the reason you're experiencing it, these are the particular options that you can do. Some you can do on your own in the community, and some you can do with our help. There's substantial difference in the approach to this condition, because suddenly that why is this happening to me, and there are options for you to take control of your health. And that changes the narrative and the attitude of the patient substantially. And as I mentioned, I think working with the charities is very, very helpful. Peer support is very, very helpful. And there are now apps that you can do, like CBT, where you can work at home in your leisure in terms of reducing your anxiety, reducing your managing your depression, managing your body image, speaking with your partner. There's a lot of psychosexual problems in PCOS, and I see that a lot in my clinic, and not particularly directly my specialty, but as a fertility expert, I see that a lot. And a lot of couples break down during fertility treatment. It's very intensive and hard. So having this frank discussion with your partner, I have PCOS, this is the barrier, please help me, that in itself is a great step towards getting better. So all these interventions, while they sound simple, but the collection of them can help someone really get control of their life and get into a better condition.
Can I ask, is it painful? Is it physically a painful condition, PCOS, or no?
No, there's no described direct pain, but there is psychosexual element in that. There is the androgenic element from the hormones. They might affect pleasure, but also there's the body image that plays into that, and the excessive weight and the excess hirsutism. So they're all compounding factors that can play into psychosexual problems.
Does PCOS increase other health problems later on in life?
100%. So the number one is that there is very high risk of type 2 diabetes, particularly for those who are overweight, obese, and with insulin resistance. So we strongly recommend monitoring the diabetic measures, the HbA1c, annually. So we recommend that to all our patients, that ask your GP for an HbA1c test once a year, because you need to be monitoring that. Even if you're of normal weight, there's still a slightly increased risk. That is then further stratified depending on ethnicity. So those of Asian and Black ethnicity have higher risk by default of type 2 diabetes, for example.
Is that because of the diet?
Like gene related.
Oh, it's gene related?
Yeah. Okay. So not just diet. Diet is a factor, but even like I'm of Mediterranean origin, and we have higher risk of type 2 diabetes. So I do my HbA1c HbA1c every year. Like,
Okay.
I have to monitor it. Same, there is a slightly higher increased risk of cardiovascular health factors, particularly increased lipids, so cholesterol, high cholesterol, that can also manifest in PCOS. There is very well described increased risk of a condition called endometrial hyperplasia, again, another big word, but in very simple terms is increased thickening of the lining of the womb. That is a precursor to endometrial cancer, or womb cancer. So the key element that we always advocate is that a woman with PCOS should have at least 4 periods per year, whether they are, induced with progesterone withdrawal, for example, or on the pill or any other measure, because long term, and this happens in the later years of life, 40 plus,
Right.
something like that, that lack of periods can make the lining of the womb much thicker, and then that becomes cancer with time. So it's important that we monitor and prevent that, and it's quite preventable. It's a relatively easy measures in terms of giving a progesterone pill or something like that to counter that. And then finally, there is obviously the mental health element that can get worse with age or as the lady gets older.
And does the mental health get worse with age, because then obviously you're kind of leading up to perimenopause and menopause, so naturally there are loads
Correct.
of hormonal changes happening.
Correct.
So, oh gosh, if you're not bleeding every month, and your hormone, so you're not bleeding every month, there's because you suffer from PCOS, you said there's a blockage there. Why would a menopause still affect you in the same way as somebody who bleeds every month? Does that make sense, what I'm saying? Because you're not having a period, so essentially your hormones are not the same anyways, right?
I understood you, yeah. So the pathway to each of these is slightly different. So in PCOS, so a period for a young lady is a sign of good health. I know it can be annoying and disrupting to lifestyle sometimes, but it is a sign that your body is enjoying normal hormones. It's a sign of good health, sign of fertility. And so the lack of these periods can further worsen the symptoms of PCOS and can bring on that increased element of the endometrial thickness that we discussed, which can become cancer in the future. So it's important to shed the lining at least once every 3 months, so that there is healthier lining that is happening, later on in the year. And that in itself plays a role into synchronizing all the different hormones. And for example, the key hormone in a period is estrogen. And we know estrogen is psychoactive. So it affects the brain, and that's why women in the perimenopause or the menopause, when their estrogen is going much lower, they start experiencing brain fog, they start experiencing anxiety, they start increasing their hot flushes, and later on there's higher risk of dementia. So the synchronicity of these hormones is a sign of health in the female body, basically.
Do you know what? I've said it before and I'll say it again. I'm convinced that the creator of mankind is man. It has to be, because only a man will have this sense of humor. So, like, women are just what?
It's difficult to get the balance right. Look, men have their own hormones that they need to get right. It's not as complex. And so,
God, it's nowhere near as
still
complex.
very privileged.
You are very privileged. Okay. So I know you touched upon the treatments that are available for PCOS. Can you give me like a really clear long line of all of the treatments that you would recommend for women who are suffering with PCOS?
Certainly. So look, at the most basic level, we always start with, education and lifestyle intervention. So exercising and eating healthy, avoiding high sugar glycemic index like food, and trying to maintain a healthy weight. So that's at the very, very, very basic level. The next level up is that we can look into the menstrual health. And that is, as we discussed, either doing something to optimize the periods happening every month, or having a withdrawal bleed, what we call, using a progesterone pill. And we call it a withdrawal basically because you give the progesterone pill for 5 days and then you stop it, and that brings on a period. So withdrawal of progesterone brings on a period. So that's why it's called a withdrawal bleed. And you do that in a cyclical fashion once every 3 months, basically, to have a period, 4 periods a year. And we explained why that is important. Or going on some sort of contraception that can suppress the lining of the womb completely, like the Mirena coil. So that can be a very, very good intervention for a lady who wants reliable contraception, who perhaps is slightly overweight, because the progesterone tablets can sometimes themselves increase weight.
Oh, really? Oh.
And progesterone tablets can themselves also cause mental health issues.
Oh.
So and they're not equal. Like they're so many different types. There are like 30 odd types on the UK market of different progesterone pills. So it takes a specialist to know the difference between them, basically. So it might not be the best fit. So a common complaint I hear from women with PCOS is that we go to the GP and they prescribe us the contraceptive pill and like as a number one solution. And the reply is very simple. Like, we treat patients, we don't treat symptoms. And so you have to understand the condition and the situation of every patient. What are they going for? What is their, contraceptive need? What is their reproductive need? What's their health situation, so that you can allocate the right treatment? The pill, the normal standard contraceptive pill, can work in a lot of women, but it might not be best fit for many other women. So it's not like it's the only or the first intervention to go to. So the pill can be good. The progesterone only pill can be good. A Mirena coil can be very, very good in many options, for example. And obviously with the Mirena, the far majority of women with PCOS will probably not have any period at all. But in this case, it's okay. I'm just highlighting in that particular element. Then the next step up is about metabolic health. So we want to make sure that the insulin resistance is low. Sometimes we give metformin, and metformin is a anti-diabetic drug, basically. It's used in diabetic patients, but there is good 30 years of research showing that it's very safe and very good in women with PCOS, can help in itself to reduce insulin resistance, regulate periods, aid ovulation, and reduce many of the other symptoms like excessive hair. So metformin is a very cheap drug, is widely available everywhere, and it can help substantially. Actually, nowadays it's like a longevity drug. So a lot of like marathon runners are taking it. A lot of billionaires are taking it for longevity.
Oh.
So yeah, it's a relatively safe drug that can be used very, very commonly, like, and easily for women. I still don't understand why there is barriers. Some GPs cannot prescribe it. Something that we advocate against, that should reduce the barrier to accessing this in the GP level. And there are other supplements that we sometimes use, but none of them have very good research base behind them, like myoinositol, like vitamin D, like folic acid. Again, they don't harm. They may benefit, they may not benefit. So that's the metabolic element. Obviously, if there is high cholesterol, there are treatments for high cholesterol that we can consider. And then the next level is the hirsutism and acne. So a lady, this could be very distressing, particularly for young ladies who are just you're starting to have their periods and then getting this excessive hair. And I've met some PCOS women who literally have like a beard, it could be quite distressing.
Yeah.
And unfortunately, there is no access for laser treatment on the NHS at present. Is too expensive. But there are several treatments that we can offer, luckily, on this front. So there are anti-androgenic treatments that we can give, something called spironolactone or flutamide or duastride. So there are different pills that are available. Again, we treat patients, not symptoms. So it's important to understand how each patient is, best fit for what treatment, and explain obviously the pros and cons of every treatment. So these treatments can help significantly reduce the hirsutism and acne, and also the alopecia, or like thinning of the hair on the top. That is very common in women with PCOS as well. And then finally is the element about fertility. And as we discussed, they can, as a first line, go through ovulation induction. Sometimes we might need to use IVF. But something to advocate for here is that we know that when a woman with PCOS is pregnant, she has slightly higher risk for adverse events in pregnancy. So they have higher risk of miscarriage, higher risk of preterm birth, smaller babies or growth restriction for the baby, high risk of needing a C-section, and high risk of postnatal depression. So again, as a fertility specialist, it's important that we counsel the women about understanding these risks. It doesn't mean don't fall pregnant, or it doesn't mean that they will happen, but basically we need to moderate their antenatal care and postpartum care so that they can receive the right support to mitigate these risks, basically.
Amazing. I have a question. So with the weight gain with women who suffer from PCOS, is it safer for them to use weight loss options that are available? I know a lot of people at the moment are using weight loss injections. Is that something that, is it okay? Does it harm them in any way, shape or form? And I also heard that people who use the weight loss injections have a higher rate of pregnancy. They're more fertile, apparently. What are your thoughts on that?
Yeah, it's a very a trendy issue. I can't tell you. I always get journalists asking me to comment that people getting pregnant while they are on the Mounjaro, is it a wonder drug? So look, it's definitely a revolution in managing weight, like the GLP-1 and GIP agonist, like Mounjaro, liraglutide or semaglutide, or many of the others. So they are literally reshaping how we manage obesity, which is great that we have this new option for women with obesity, and particularly for women with PCOS. So, however, I'm not for using them like Tic Tacs, like it's happening right now, because everyone is getting them online and it's so easy, and you just pay for it. It's literally no barrier. There are some concerns is that you can lose the weight, and when you are losing weight, you tend to lose both fat and muscle. But then when you're off them, you tend to regain some weight, but you gain it mostly fat. So you might lose your muscle mass with these. These are early, sort of long-term reports, because, don't forget, they are relatively new drugs. So we're still getting more long-term data for them. So there is that concern. They're not best fit for everyone. So you have to take into the consideration other sort of health conditions that are happening. No chronic liver disease or kidney disease, for example, to give an example for these. And the most important one that many women forget, or they don't get told, is that they can have teratogenic effects on the baby.
What is that?
So basically malformations for the baby.
Oh.
So you need to have a washout period. So if you use a Mounjaro or Wegovy or any of the others, you need to have 3 months when you're off them before you try for a pregnancy. And while you are on them, you need to have reliable contraception. So there's an FDA warning about these. So you should not try to get pregnant while you are on them. So these pregnancies that happen while on them, they're actually unsafe pregnancies. So they need further following in fetal medicine and so on.
Wow.
So that said, so in my practice, we do prescribe them for women who are hoping to lose weight and they're hoping to get pregnant, as we think of it more as a catalyst of, helping someone to achieve the desired weight loss and then getting into a healthy lifestyle that can maintain that weight loss. Because there's a lot of reports that post and Mounjaro, you gain back the weight very quickly.
Yeah.
So we advocate for it to happen under medical guidance with the support of a dietitian that can, develop a particular individualized treatment plan with no sugar, no bad elements into your diet, so that, once someone lost the weight, they have this window of washout, then they can actively try to get pregnant, because then this is the point where they are at their best health to actually achieve a healthy pregnancy. So if you think about it in that context, it becomes a very positive and welcomed addition.
Yeah.
But if you're using it willy-nilly, just buying it offline, it can have some risks.
Yeah, I fear we're living in this space where everything is just fast, and nobody we have no patience, and everything is so easy. So eating well and working out and doing all of these things takes so much energy, and people are just nah, I'm just gonna go and get some Mounjaro.
Yeah, and look, it works in some patients, but in some others we sometimes recommend, for example, bariatric surgery. So in someone who's BMI like 40 or 45, they might be better off with bariatric surgery for the long term.
Bariatric surgery.
Weight loss surgery. So it's becoming safer and safer. It's still a major surgery that has its downsides, but in a particular group of patients, it can be a fantastic option for them. And there's less risks of weight regain with bariatric surgery, for example. Okay. The problem is that the waiting time for the NHS is at least 1 to 2 years nowadays for such surgery. So, it's a big problem in terms of resources.
Yeah.
There is also some success with other and like more, let's call them aggressive lifestyle interventions, like the liquid diet.
Right.
Where you go for 3 months only on shakes, for example. And
is that physically possible? You could.
Yeah. It's actually a very well established and researched intervention, and it is very successful in, say, regressing those who are pre-diabetic to non-diabetic.
Okay.
And there are many companies offering it right now. Some of them are more robust than others, but basically they send you set shakes that have sufficient nutrients and vitamins and so on. So for 3 months you do nothing but shakes, and then they do a food reintroduction period for like three other months, and then a weight maintenance period for another 6 months. And it has a lot of success, similar success to Mounjaro. You do lose 7 to 10 kilograms over this period. So it can be very successful, and obviously without needing to take the Mounjaro as a medication, cost-wise they're probably very similar.
Right.
But so it's not just like, by default Mounjaro is the only option. Again, depends on every person's situation, what they're going for, and how they feel going for the future. If I think Mounjaro is a very helpful option, but needs to be done within safe boundaries.
For anybody who has just been diagnosed with PCOS and they're feeling really, really overwhelmed, lost, confused, what advice would you give to them on navigating this new diagnosis that they've just been given?
First and foremost, try to work with your health professionals to understand the condition. Second is, I obviously look for reliable information online. And I know I'm emphasizing reliable because I get some patients who are like now asking ChatGPT to get them the information. It can, it probably giving you a bit better information than Google, but it's still not a very reliable source.
I actually know somebody who uses ChatGPT as like their day-to-day best friend. And I'm like, you have to stop. This is going to cause you psychosis.
Yes,
Stop,
exactly.
Leave it alone.
A weird bonding between human and AI nowadays. So I don't think AI would replace doctors anytime soon, but maybe in the future we'll see. Hold the space on that. But I think finding reliable information online, and I think it used to be like I get patients who tell me, "Oh, my GP is not listening to me." Yeah, and I say, "Look, change GPs. Like it's not that complex, and it's not like I don't know if it is the same as like when you want to change accountants, you feel like, oh my God, I'm going to need to move all my accounts. It's like, so what? Change GPs, find someone who would listen to you."
Yeah.
And nowadays with like virtual telehealth, no matter where you are in the world, you can find an expert in this area that you think will help you, will listen to you, and you can go seek their we're not bounded by geography like we used to be. Like, you have to find an expert in your city or something like that. It's very easy to do like a consultation with anyone that you think will actually listen to you and speak with you and understand your situation. Speak with a dietitian who's a specialist about this. Speak with a fertility specialist who can give you an opinion about this. So take basically ownership of managing your health through more information, and don't feel like like a hostage. My current GP practice is like that. Okay, fine. They might not understand it, which is a shame, but it doesn't mean that you remain the hostage of that situation and you don't seek other resources to improve your health.
Amazing. You mentioned charities that you work with and charities who are really useful for PCOS. Can you name some of those charities?
Sure. So the most established charity in the UK is PCOS Verity PCOS, and They're very, very fantastic group of volunteers, and they do really amazing work. We do a lot of educational courses and educational events with them, so very supportive of their work. And they have free resources available online. Like if you go on their website, you have like leaflets and reading materials. They do like peer support groups as well, like regionally, which is very helpful. There's PCOS Action, which is again very helpful. There is an American one, PCOS Challenge, and they do have useful resources online as well. And also the Australian version, Jane Heals, and they do have quite a lot of useful information. We can put like links to these in the show notes.
I will.
And then people can just go on them and digest all the information. And I like the quality of the information the PCOS charity, the Verity PCOS charity put out, because they work with experts, with health experts in the field to produce the content. So it's quite reliable and it's quite good quality.
Amazing. Dr. Basil, where do we find you? Now, I know you're not on Instagram.
Yes.
I've noticed that all these amazing doctors and scientists, they're not on social media. And I understand why now. Before I was like, well, why not? Now I get it. I understand. But where do we find you if there's somebody who's watching this and they want to get in contact about fertility and their PCOS? Where can we find you?
Sure. So I'm active professionally on LinkedIn.
Yeah.
And I have my own website, so if you type it in Google, it will come out. I'm happy to answer questions. For Instagram, I keep it for personal life with me and my wife and my daughter. So we keep it a bit more personal. But otherwise, to university website or personal website, I'm always around on the ether.
Again, thank you so much for coming on the show. You're always such a breath of fresh air, so informative, and I can't wait to have you back again for another episode on a different, maybe a fertility one.
Yeah.
And yeah, thank you for coming. You've been an absolute pleasure as always.
Always a pleasure, and thank you very much for all the efforts you put into this. And I'm sure a lot of women are very grateful for all the information that they're getting through your podcast.
Thank you.